Good evening. I'm Michael Schutz from the Office of Sponsored Research. Welcome to Immaculata University's Graduate Research Symposium called Research in the Round, celebrating our students and our faculty. During this virtual event, students present highlights of their research performed in collaboration with their faculty mentors. Please refer to the IU Research Symposium program for a listing of all student presentations. Within that program, links to Google Meet rooms are provided and arranged by various graduate programs. You may move from one room to the next to view and listen to different student presentations. A moderator will now share the student video presentations and allow for a brief question and answer period following each presentation. Thank you for supporting our students and our faculty. We hope that you enjoy this wonderful student event.
Hello everyone, my name is Kyle Badman and I am a doctoral candidate in the PsyD program at Immaculata University. My dissertation entitled Supervision in Neuropsychological Assessment, Training, Practices, and Perspectives focuses on the subject of neuropsychological assessment and supervision. Firstly, I'd like to thank my chair, Dr. Yela, for helping me with this research, as well as Dr. Keaveney and Dr. Pernetta for their critical support in the development and of this research. So, for our methods for the research, we contacted licensed psychologists who provide supervision to trainees through listservs of professional organizations in clinical neuropsychology, as well as through a snowball sampling procedure. A survey was dispersed on the professional organizations listserv. Each survey utilized a 5-point Likert scale to assess the supervisor's perspective on how proficient supervisees must be in various core competencies of neuropsychological assessment at different levels of training in order to be prepared to advance to the next level. The design was a between-group comparison examining the supervisor differences across trainee levels, including practicum, internship, and postdoctoral training on dependent measures related to trainee competency and supervisory feedback. As such, supervisors' ratings on the required level of proficiency in each competency were compared across developmental levels. The identified competencies of neuropsychological assessment included clinical interviewing, clarifying referral questions, test selection, test administration, test scoring, report writing, diagnosis, recommendations, providing test feedback, ethical and legal issues, as well as multicultural considerations. For the results, we collected demographic data about the supervisors and information about their supervision practices were reported. Statistically significant differences were identified across all developmental levels on all competencies with the exception of test administration. Test administration showed no significant difference between ratings for interns and postdocs. Supplemental analyses were also conducted to explore differences between competencies within each developmental level of training. For practicum trainees, test administration and test scoring were rated significantly greater than all other competencies. However, they were not different from each other. Multicultural competency was rated significantly greater than diagnosis and recommendations and providing test feedback. Ethical and legal issues were rated significantly greater than recommendations and providing test feedback. Lastly, providing test feedback was rated significantly lower than all other competencies at this level of training. Additionally, for interns, test administration and test scoring were related significantly greater than all other competencies with the exception of each other, and providing test feedback was rated significantly less than test selection, ethical and legal issues, and multicultural considerations. Lastly, no statistically significant differences were identified between supervisors' ratings of competencies at the postdoctoral level of training. So for the precedent study, we had an explicit focus on the supervision of neuropsychological assessment, the identification of competency-based benchmarks relevant to neuropsychological assessment, and obtaining ratings on these benchmarks of trainee emergent readiness to progress to the next level of training for 3 different professional levels of professional development. Field suggested that test administration skills are learned relatively early in the training process through classroom instruction and clinical training experiences. Also, supervisor ratings did not show a statistically significant difference between interns and postdoctoral trainees. The finding of test administration, notwithstanding, results of the present study support maturation of level across the continuum of training from practicum through postdoctoral supervised experiences. Examination of the differences between supervisor ratings of competencies within each developmental stage provided additional information about the supervisor rating of trainee skills and their importance across different levels of training. So for further research, there are many different avenues to explore in relation to neuropsychological assessment supervision. One area includes comparison of board-certified and non-board certified neuropsychologists across competency areas. A second area includes the comparison by experience level. A third area involves refining the non-applicable question utilized in our survey. A fourth area involves evaluating student perspectives on neuropsychological assessment at different levels of training. And a fifth area might look at comparison of supervisor-supervisee ratings, I should say. As can be seen from these options, there are many areas to investigate when exploring neuropsychological assessment supervision practices across the developmental spectrum. If you have any further questions, you can contact me at kbadman@mail.immaculata.edu. Thank you very much and have a good day.
Hello, my name is Nina Collins, and I will be presenting on the effectiveness of cognitive behavioral therapy for immigrant children and adolescents who are diagnosed with post traumatic stress disorder. So, my meta analysis looked at first generation immigrants, meaning those who were either born outside of the host country being where they're seeking refuge or seeking a better life. So either those who were born outside of the host country or those who have at least one parent that was born outside of the host country. So I started off with about 20 articles, and based on my inclusion criteria, those articles dwindled down to about five that were used for my analysis. And I pretty much was looking for randomized controlled studies, peer reviewed articles, studies that looked at the efficacy of CBT within the child and adolescent immigrant population with PTSD. Children had to be between the ages of 0 and 18 years old. I also was looking 10 years back initially, but then had to expand that to about 20 years back just because of the limited amount of information I was finding. And so I'll move on now to talk about effect sizes. Um, my studies overall showed a medium effect size about zero point 0.7, which tells me that cognitive behavioral therapy appears promising for this population that I'm looking at. And to be more specific, I looked at several treatment models. I looked at EMDR, which has components of CBT. I also looked at 4net, group CBT, and NET. So I'll just talk about those quickly. EMDR, which showed the least effect size, a very small effect size, was found to be helpful within the child and adolescent immigrant population. For those who have PTSD, it was found to be helpful um, for children in situations where there were language barriers, where they couldn't really understand concepts or express themselves well. So they were saying that there was a lot of wiggle room within that particular treatment model to adjust for those kinds of problems. Also, with regards to 4net, which is my second least effect size here, 4net is a forensic offender rehabilitation type of narrative exposure therapy, which was applied to young men who had a history of being child soldiers or those who pretty much had lived on the streets for a long time. So, and also those who they had a tendency to be aggressive. And they found that Fornet was very effective in reducing aggression symptoms. However, appetitive aggression, which is like a drawing to aggression, was not significantly changed. And so moving on, I looked at group CBT within a school setting. Both of the studies that addressed a refugee or asylee population yielded pretty impressive effect size. One was medium effect size, the other was a pretty large effect size. And they found that not only did this treatment model help reduce, the symptoms of PTSD, it was also effective for other co-occurring problems like depressive symptoms. And I looked at a study that applied narrative exposure therapy to a child and adolescent population with PTSD, and it was found to be very effective for the reduction of intrusion symptoms. I also looked at this KitNet, which is a child adjusted model for narrative exposure therapy. It was very effective for externalizing behaviors, which may have implications for the juvenile population. And just moving on to my limitations here, I pretty much can say that, obviously, the amount of articles that were utilized were relatively small, so there would be a need, in future to expand that as much as possible, as much as is available. Also, the studies themselves utilize pretty small sample sizes, which could be better. There were some circumstances where the clinicians were utilized in both treatment role and being an assessor as well of outcomes, which, you know, where there could be inherent biases within that. Also, there was a common theme that I saw in most of the studies where um, they were obtaining information based on self-report, which again, there could be biases within that, is given that, there could be socially desirable responses and you're relying on a population that's had a lot happen to them. And just to be able to retell that story accurately in and of itself is already difficult. And then to see that that was, in many cases, the only means of gathering information about them in the absence of psychometric data. I feel like that could be better as well. Future research would definitely utilize a larger scale study. Also, investigate which treatment models may address appetitive aggression, like what was seen within the Fortnite application. Also, future research could test the efficacy of specific treatments in addressing specific types of trauma within certain gender populations, and also how do we help treatment non-responders, like kids who just don't respond to these traditional treatments. We could look into that as well, and also test treatment efficacy regarding more current day realities that we're experiencing right now that may be sources of um, trauma for the immigrant population. Thank you very much for your time. Shout out to Immaculata and Dr. Gaines. Thank you, and I look forward to your questions.
Hi everyone, thank you for virtually stopping by. I'm here to talk about my dissertation research, the rates of telemental health training in APA accredited doctoral programs. So we know that there's a large unmet need for mental health services across the United States, and we also know that these needs are concentrated in the South and on vulnerable populations. So telepsychology could be a potential way to meet these needs in this context referring to behavioral or mental health services provided via technology, which could be phone, video conferencing, or online mediums. It's seen to have a lower stigma than face-to-face counseling, be as effective as face-to-face counseling, potential lower community hospitalization costs and rates, and provide immediate services that are accessible from anywhere. However, the training rates of telemental health are seen to be quite low and are described to be either on the job or the exception rather than the rule. 86 mental health professionals at a VA outpatient clinic took a survey in which 5 or 15% reported formal training, and most said they did not feel adequately trained to provide telemental services in 2009. However, the research in this area is quite low. But we also know that telehealth use is growing with a 45% annual increase from 2004 to 2014. Now, we have a responsibility to train psychology students in the modalities that they can be expected to see in the field. So this dissertation aimed to find out how much training is really occurring. We looked at 325 psychology programs that are APA accredited, which included clinical programs, counseling programs, combined clinical counseling programs, PhD programs, and PsyD programs. We looked at publicly available documentation of this program, so that included student handbooks, course catalogs, websites, promotional materials, and whatever else was available. And we searched these documentation for keywords including telepsychology, telehealth, distance, and remote for hit words. And then we used these hit words as a baseline to assess how much training was occurring throughout the programs. Of the 325 programs, 27, or about 8%, had explicit references to telepsychology, which in this case means the client receiving psychological services from a distance. And this was about 90 hit words throughout these 27 programs. And they were put into categories for assessment. Those categories included class-based education, practicum opportunities, catalogs and professors' interests, COVID-19, and promotional material, and a miscellaneous for whatever didn't fit in the other categories. So of these categories, only class-based education and practicum opportunities explicitly refers to training. So the practicum opportunities was the biggest category, which is in line with the literature that suggests that most training is on the job. In terms of class-based education, although it was one of the larger categories, only one program had a class that explicitly referred to the training of telepsychology, and the other mentions telepsychology was included into another course, such as an ethics class or a DBT class. So overall, we are finding support for the literature that sees overall low telepsychology training rates. Now, we do suggest a repeat study, as this study was conducted right before the pandemic hit, so a repeat study would be good to confirm these findings. Future directions could also include bringing in school psychology programs, master's programs, bachelor's programs, or non-accredited programs to get a broader scope of practice.
Hi, my name is Christina Jones, and I am a graduate student in the Clinical Mental Health Counseling program. I am talking today about choosing assessments for bipolar disorder. Bipolar disorder is a brain disorder that causes changes in a person's mood, energy, and ability to focus. People with bipolar disorder experience mood episodes with intense emotional states lasting days to weeks. Periods of neutral moods are generally experienced, oscillating with depressive and/or manic or hypomanic moods. Bipolar disorder can be broken into 3 categories. Bipolar I disorder, where a person experiences a manic episode. To be diagnosed with bipolar II disorder, the client needs to have experienced at least 1 major depressive and 1 hypomanic episode with a return to regular function between episodes. The last diagnosis is called cyclothymic disorder, where hypomania and depressive symptoms occur more frequently, but with less severity than bipolar 1 or 2, and during a 2-year period, where the symptoms have lasted for at least half the time and have persisted for more than 2 months. Individuals with a family history of bipolar disorder are at higher risk of having the disorder. Environmental and psychological factors can also trigger a manic or depressive episode. I chose 2 assessments diagnosing bipolar disorder. The first is the Mood Disorder Questionnaire. It is a self-report paper and pencil inventory consisting of 13 yes-no questions derived from the DSM-4 and clinical experience, which are then followed by a yes-no question about duration of symptoms and one final question about functional impairment scored on a 4-point scale. In a study conducted to assess the sensitivity and specificity of the questionnaire, the reliability coefficient was found to be 0.9. This suggests that the Mood Disorder Questionnaire is effective at determining a positive presence of bipolar spectrum disorder. The study was conducted in 5 outpatient psychiatric clinics, which primarily treat patients with mood disorders, especially bipolar disorder. The other assessment was the Bipolar Depression Rating Scale, and it is a 20-item scale containing items reflective of objective assessment and self-report by the client. This scale is designed to be administered by psychiatrists and other trained observers. It comes with a manual for the rater's guidance. The Bipolar Depression Scale is specifically designed to detect and measure the specific signature of bipolar depression. The reliability coefficient for this scale is 0.92. Validity was established by comparing the results of the Bipolar Depression Rating Scale with those of the Hamilton Depression Rating Scale and the Young Mania Rating Scale, among others. I also chose 2 non-traditional assessment tools for bipolar disorder. The first is neuroimaging. Neuroimaging can be used to further assess or confirm the presence of bipolar disorder. Current literature on this method is based on a diagnosis of bipolar 1 and indicates that neuroimaging can be used to measure abnormalities in neural regions of the brain that are associated with important domains of pathology in bipolar disorder. This pathology includes impaired cognitive control, abnormal emotion processing, and mood instability. The areas of focus in the brain are the prefrontal cortical and subcortical limbic regions. Abnormally decreased activity in the prefrontal cortical regions and increased activity in the subcortical limbic regions were seen in the scans that may persist during remission, depression, and mania, during cognitive control and emotional processing, respectively. Due to the fact that most individuals that have known cases of bipolar disorder have been medicating to relieve symptoms, neuroimaging scans were performed on both medicated and unmedicated individuals. The scans showed that medicated more than unmedicated individuals with bipolar disorder demonstrate levels of subcortical limbic activity to emotional stimuli that are similar to those observed in healthy individuals during cognitive tasks. Actigraphic assessment of motor activity is another non-traditional method for assessing bipolar disorder in individuals. For this method, I looked at a study performed with individuals at an inpatient hospitalized setting. The study compared recordings of motor activity in mania, bipolar depression, and healthy controls. Actigraphy is a method of activity monitoring using a wrist-worn device. Activity was recorded over a 24-hour period. The individuals with depression were less active than the healthy controls. An increase in variance of activity was observed compared with the healthy controls. The results indicate a significant difference between the 3 groups in the regulation of motor activity, which indicates that the use of actigraphic assessment may be a useful tool in assessing for bipolar disorder. In my opinion, the Mood Disorder Questionnaire, Bipolar Depression Rating Scale, neuroimaging scans, and actigraphic motor activity monitoring are all useful tools for assessing bipolar disorder, and there may be a benefit from using them in tandem to get a more complete assessment of bipolar disorder. Thank you.
Hi everyone, my name is Bisma Khan and I'm a PsyD student, and I conducted a meta-analysis with the help of Dr. Games titled Childhood Trauma and Adult Attachment Style. So the main reason I was really interested in this topic is due to the prevalence of childhood trauma that occurs worldwide, and just knowing the lifelong impact it could have on children, and it can continue on to adolescence and even adulthood if it's not properly mended. So due to this fact and knowing previous research, I I became more interested in expanding on this topic and understanding more about it. So, more specifically speaking, previous research has stated that individuals who've endured childhood traumatic experiences are more likely to develop anxiety disorders, engage in self-harming behaviors, dissociate, and much more, which is unfortunate and is the main reason why I wanted to expand on understanding more on how trauma can impact adult attachment style. So in order to do this, I conducted a meta-analysis and I searched through a bunch of different databases, and I've identified 7 articles that aligned with my criteria, which was basically at least an adult with at least one childhood traumatic event that occurred. And the trauma could be or was like physical abuse, sexual abuse, neglect, natural wildfires, and other types of trauma as well was included in all the studies. So then I calculated the effect size for all of the studies, and I found a weighted means of 0.54, which according to Cohen's D classifications would be a medium effect size, which really just means that my results suggest that enduring a childhood trauma can play a role in altering one's adult attachment style, more so in a negative way, kind of like towards insecure attachment. So I think these are very important results for us to recognize as mental health professionals. But I do want to point out that the results should be taken with caution, just because I only had 7 studies in my meta-analysis, so I believe future researchers should include more studies and studies that originate from different countries. All the studies that I chose were from 3 countries only: the US, Turkey, and Australia. And another aspect that people can focus on, researchers can focus on, is the including males within the sample size. Right now, a lot of research is mostly surrounded around females. So I think that would be really important to understand how childhood traumatic experiences affect both male and female attachment. That's all I have. Thanks for listening. Bye.
My name is Caitlin Rubright, and I did my poster presentation on assessing for schizophrenia. My faculty sponsor was Dr. Christy Brumfield. So before I start discussing the different assessments and alternative testing measures of schizophrenia, I would like to give a little bit of background on the disorder. So schizophrenia is a disorder of the brain that affects one's abilities to think, feel, and behave clearly. This disorder affects less than 1% of the total population and affects both men and women equally. The DSM-5 has multiple categories of criteria that need to be met in order to receive a diagnosis. An example of this criteria is that 2 or more of the following for the majority of 1 month need to be met, which can include delusions, hallucination, disorganized speech, and others. Assessments and alternative testing measures have been created and used for decades to better assess for schizophrenia. The first assessment that I'm going to discuss is the Scale for the Assessment of Positive Symptoms. This was created in 1984 by Dr. Nancy Andreessen. It is only for adults, so it can't be used for children, and it's a list of only positive symptoms. So by positive symptoms, I mean something that has been added to the personality, such as someone suffering from hallucinations and/or delusions. This assessment has a whole list of different positive symptoms that are scored between 0 and 5. 0 meaning that there is no symptoms, and 5 being the most severe of that symptom. This assessment is considered both valid and reliable. The second assessment is the Scale for the Assessment of Negative Symptoms, which was also created in 1984 by Dr. Nancy Andreessen. This assessment, again, is only for adults, but instead of positive symptoms, it comes with just a list of just negative symptoms. And by negative symptoms, I mean something that was taken away from the individual's personality. A good example of this would be a blunted affect. Once again, it is scored from 0 to 5, 0 meaning that that symptom is not there or present, and 5 being that it is very severe. This assessment is also considered to be both reliable and valid. The two alternative testing measures that will be discussed are fMRIs and a blood test. fMRIs have been used since 1984 in order to diagnose schizophrenia. Since then, there have been hundreds of studies that have been completed, which shows a 97% overall accuracy as early as the first episode. In the fMRIs, researchers actually noticed different areas in the brain. So some of them were smaller. There were issues with the ventricles and deficits in the hippocampus. They also found something interesting that showed that the auditory and visual areas of the brain would light up even if there was no external stimuli. The second alternative testing measure is a blood test. This is rather new, only being created in 2017 by Dr. Deanna Kelly and her team at the University of Maryland. So this test was done, and there was experiments with a control group as well as those who were living with schizophrenia. What happens is they take the blood, and it's a very rapid test, and they use genetic markers in order to see who is battling with schizophrenia and who is not. They were easily able to differentiate between the control group and those who were diagnosed with schizophrenia. This test also gives insight into the future of whether or not someone may end up dealing with schizophrenia or another disorder in the same category. So while each of these assessments and alternative testing measures are great for diagnosing schizophrenia, there are some critiques. For the scale for the assessment of positive symptoms, as well as the one for negative symptoms, they can only be used for adults. So even though children can be diagnosed with schizophrenia, they don't work for children. They're also very time-consuming tests. So if someone is brought in the middle of an episode, then these assessments may not be the best for them right away. Lastly, it takes a lot of time and training in order to be able to administer and score both of these assessments. For the alternative testing, the fMRI and the blood test, the critiques are the same for the two. They're very costly. Insurance companies do not want to pay money for them to receive these types of diagnosing. They would prefer them to go in setting and be diagnosed by a person. And the second critique is that they're not widely accessible. Not everywhere has an fMRI machine, nor do they have the money to be able to pay for that all the time. And the blood test itself is only available in Maryland, but they are hoping to expand.
Hello, how you doing? So my meta-analysis was done on the impact of acute stress on memory and attention. Basically focuses on the crucial role that information retained throughout our lives. We encounter countless streams of information from all over throughout the day, making it impossible to basically take in every single microparticle that we encounter, from day-to-day activities to long-term events, serious events. We experience acute stress more often than we think, and our reaction to the stress that we encounter determines how our memory and attention are affected. So this meta-analysis looks at how our attention and memory are affected through acute stress, and at what part of the process, if we are met with stress, in the, let's just say memory, for example, whether it's in the encoding or recalling phase of memory, at which particular part does it affect us the most? So this review, examines how acute stress affects the memory and attention, along with how it may improve these two cognitive functions and harm them, and also some potential interventions for the future. The literature was searched using a few different methods. First, a comprehensive literature search in bibliographical databases was done, which the school websites psych articles, psych books, psych info. And all of the terms that were included were all relative to acute stress, memory, and attention. Also, Google Scholars was used. The same search words were typed in. And if something was found on Google Scholar, it was also found on the school's online database. So these were the search engines that were used for all of the information. The results, out of 6 articles that reported the impact of acute stress on memory and attention, they were reviewed for inclusion in this meta-analysis. The selected studies reflect the impact that the participants' memory and attention after they were induced with acute stress. 2 of the studies were excluded from the analyses for not providing enough data to obtain an effect size, and they're listed in the parentheses. And 1 was excluded because participants were not considered for the interventions, and it's also in the parentheses. The overall effect size was calculated using 3 of the different studies that examined the impact of acute stress and memory on attention. The studies varied in terms of their outcome measures reported. So only 1 overall effect size that sort of incorporated a broad range of outcomes was measured and calculated for Cohen's D, which ended up being 1.20. It's a pretty large effect size. Conclusions. The results of the meta-analysis indicate that acute stress has an impact on memory and attention. So the participants that were induced with a form of stress, mostly cortisol injections, this allowed the experimenters to examine their heart rate, their blood pressure, and their cortisol levels before they started the task that they were given prior. And a lot of the studies found that the timing of the stressor determined whether the impact was positive.
Hi everyone, welcome to my presentation. My name is Okara Shepard, and today I will be discussing my meta-analysis on postpartum depression and its impact on infant development. Postpartum depression is a depressive disorder marked by depressed mood, tearfulness, feelings of inadequacy regarding motherhood, irritability, and challenges bonding with one's infant. Factors such as shame, stigma, and culture contribute to underdiagnosis, causing potential patients to fall through the cracks and not receive the care and support that they need. Seeing that postpartum depression can affect a mother's breast milk production and bond with their child, I conducted a meta-analysis with the help of Dr. Games to see how this possible lack of attunement could in turn impact infant development. I included articles that were published between 2005 and 2020 using terms that were synonymous with postpartum depression and infant development. The populations and majority of the studies chosen were quite small, possibly due to previous mentioned factors that contribute to underdiagnosis. Studies that included the mother and child dyads where the child was aged 2 and over were excluded as we were focusing more on infancy in this study. Specific aspects of infant development examined were social functioning, imitation, emotional negative tone, and cognitive functioning. One study by Granat et al. Showed a medium effect size, whereas the remaining studies yielded small effect sizes. The meta-analysis yielded an overall small effect size. You can find all of this information in Table 1 in the results section of my poster. Studies showed that psychosocial functioning was delayed in infancy in babies whose mothers were diagnosed with postpartum depression. However, some studies showed that after 13 months, certain aspects of development resolved to normal development. It is possible that postpartum depression alone is not enough to impact infant development long term, and that other factors in addition to this, such as comorbid diagnoses, lack of support, and socioeconomic status can together aid in prolonged psychosocial delays. Further research should prioritize larger scale and diversity inclusive studies. It was difficult to generalize these findings due to the low number of participants and low diversity. Longer term studies should also be prioritized to examine if a trajectory of delayed development persists further past the age of 1 and additional factors that might contribute to that. Research should also focus on utilizing consistent methods of evaluating postpartum depression and infant development by using the Eidenberg Postnatal Depression Scale and the Bailey Scales of infant and toddler development, respectively. This will allow for consistency across studies. The goal is to intentionally screen for postpartum depression during postnatal visits, which may lessen the stigma if normalized as routine. This will allow increased competence and comfortability for medical professionals and make it easier for patients to disclose challenges without feeling embarrassed so that they can receive resources that they need to help them earlier. So I hope you all enjoyed my presentation. Thank you for coming.
Smith. I'm in the PsyD program at Immaculata. I completed a meta-analysis for Research and Statistics Part 2. And this research project was to assess the risk factors for individuals who might attempt suicide if they have bipolar disorder 1, in order to help reduce the chances of suicide among these individuals. So along all the psychiatric illnesses, bipolar disorder has the highest risk of suicide attempts. It's 20 to 30% higher than the general public. And different risk factors have been revealed to be associated with suicide attempts, which would be how long the illness went on and left undiagnosed, if it was an early age of onset or the first episode type, family history of mood disorders, gender, presence of a personality disorder, history of abuse, among others. So because there are so many different risk factors, I decided to just tease out a few to see which would be the most present and tied in gender to it as well. So the first question I had was to assess if gender was associated with suicide attempts, and all for individuals with bipolar disorder 1. And then the second research question was, does comorbid anxiety increase the likelihood of a person attempting suicide? And then the third research question was, does the presence of an SUD, substance use disorder, increase the likelihood of a person also having a suicide attempt? I did an extensive literature review to start off, but for time's sake for this project, I narrowed it down to only 5 articles for this meta-analysis. And the articles were mostly international studies. They had smaller sample sizes from about 150 participants to a little over 1,000. And they were limited to only outpatient settings, since inpatient settings made it more complicated with completed suicide versus attempts. So just to narrow it down even more. I needed to exclude articles that didn't specifically talk about gender, anxiety, and substance use disorders. Then in order to calculate the weighted effect sizes, I used the odds ratio and calculated the average weighted effect size using the Cochran-Mantel-Heinzel estimation equation. So the results of the study that I did show that females are 2.1 times more likely to attempt suicide compared to males. For anxiety specifically, I needed to take out the article by Katamati, since they did not specifically say an anxiety disorder in there. But if a comorbid anxiety disorder is present, the likelihood of a suicide attempt for individuals is 0.181 times higher compared to not having an anxiety disorder. And if an SUD is present, 1.03 times higher than not. When I compared gender and the comorbid disorders, the results revealed that females are 1.52 more times more likely to attempt suicide if anxiety or an SUD was present. Then looking at only gender and anxiety, females were 1.3 times more likely to attempt suicide, well, they were 2.41 times more likely to attempt if a substance use disorder is present. So comparing these to Cohen's d, these are small effect sizes, although they still have important implications for the likelihood to attempt suicide among females. So there were some limitations in the study. Since I did not include inpatient samples, this might limit the sample size and may be underrepresentative of the overall population. And again, I needed to take out the one article in the meta-analysis since it did not report anxiety specifically. So this may change the comorbid disorder data. And then overall, there are important implications for early intervention, to keep a close eye on individuals who might be at risk. And there are a lot of different studies that can be pulled from this, including the inpatient settings, looking at personality disorders that kept coming up in the research, and assess for any other associated risk factors. So I hope you enjoyed my presentation, and I will see you at the research in the round. Thank you.
Hi, my name is Katie Trainer, and I'm a second-year PsyD student in the clinical psychology program. My faculty mentor is Dr. Maria Cuddy Casey, and we conducted research on social media's impact on suicidality and feelings of worth. Social media consists of the sharing of information and pictures among friends, family, and even strangers. Some of the more popular social media platforms include Facebook, Twitter, Snapchat, Instagram, and YouTube. The use of social media has skyrocketed, where in 2005, only 5% of Americans reported the use of one or more social media platforms. However, by 2019, this number had risen to 72%. While social media can enhance social connection, research indicates that social media use is also associated with negative outcomes, such as envy, romantic jealousy, decreased self-esteem, increased loneliness, and depression. The hypothesis is the daily frequency of checking social media is related to FOMO, negative feelings about the self, and suicidal ideation. FOMO, also known as the fear of missing out, may drive the use of social media to avoid negative mood states and the feelings of being out of the loop, but also has a negative impact on mental and physical health. While interacting with social media can provide positive benefits, including increased communication and sense of community, excessive use may also cause or exacerbate mental health problems. The ability to display the perfect life on a media platform impacts the feelings of self-worth. Given the accessibility and high rates of utilization, it is essential to explore the influence of social media on suicidality. Our literature research consisted of some topics including fear of missing out, suicidality expressed on social media, contagion effect, suicide prevention efforts on social media, and protective factors. For a method, we had 105 participants between the ages of 18 to 63 years participated in taking an online survey administered on various social media platforms over a 2.5-week time span. 104 participants provided their gender, with 81 participants being female, 21 being male, and 2 being non-binary. 105 participants provided their ethnicity, with the majority being Caucasian and the next being African American. The participants also had the opportunity to write in their ethnicity. Occupations included anywhere from students, licensed clinicians, engineering or administrative management, and other healthcare professionals. Our results: 88 participants responded no, whereas 17 responded yes on whether they have looked up suicide-related terms on the internet. 46 participants did not know anyone who has attempted or completed suicide. 35 participants reported knowing someone who's attempted suicide, and 24 reported knowing someone who completed suicide. Most subjects denied thoughts of suicide and provided their reasons for not engaging in suicidal behavior included in the graph below. The primary reason included family, but is also including the use of distractions, fear, or faith. When the Pearson's R correlations were run for the hypothesis, we had found the frequency of checking social media was statistically related to the number of hours on social media, feeling worse about the self, thoughts of suicide, increased FOMO, and hopelessness. For our conclusions and further research, the study served to explore the impact of social media on individuals' mood and suicidality. Further considerations of the findings indicates that increased fear of missing out and negative feelings of self is related to social media usage. Potential confounds need to be considered and included in the time period in which the survey was rolled out, being at the start of the COVID-19 pandemic. As a result of the pandemic, it is likely that social media usage increased as people were more inclined to stay at home. Further research would continue to look into the relationship between time spent viewing social media, negative evaluation of self, and suicide ideation.